Good day. I would like to discuss with you today the concept of the elderly pelvic injury, which might be becoming a dilemma in care of this injury. I have no personal disclosures on this. I would like to thank CurvaFix for their willingness to present to our institution a research grant for resident research with regards to this presentation. And I would also like to thank Dr. Paul Romans and Dr. Robert Meek for their input into this presentation as well. Let's begin with a case. This is a 75-year-old lady who is very active in the community and does some gardening. She has a little bit of hypertension, some asthma. While gardening, she tripped over her hose, was unable to walk due to pelvic pain. She's taken to the emergency department where her vital signs are stable and she has no other issues at all. What are we going to do with this lady as you look at her x-rays and see with the white arrows where her pelvic ring fracture is? It does not look very significant or very displaced. If she was a hip fracture, we would really know what to do. We know now that the faster the patient gets to the operating room with a hip fracture, particularly within 24 hours, the better their care. We understand the need for bone health for other aspects such as fracture liaison services. But with this injury, it is not quite sure exactly what is next to do with this. Is this non-operative? Is it an operative fracture? What is the timing? Should it get done fast? Should the patient be mobilized quickly? Who gets what and when? And the other question might be, is who will be providing the care for this patient? So what I'd like to do in this talk is to go through and understand the problem. We'll discuss the diagnosis and classification, look at various management of this injury, and then see some of the recent reviews upon the results of some operative treatment and non-operative treatment. The problem is difficult to define. When one talks about the elderly fracture, automatically age comes into it, but this really isn't the issue. The issue has to do with bone and osteoporosis or osteopenia. It's a mechanical problem in that the bone is weak and it becomes fragile and will fracture. The other interesting fact is a change in the operative management of pelvic fractures from large open fracture treatment to percutaneous techniques, which changes the way and the outcome with these for elderly people. The bone. Well, osteoporosis and osteopenia is from a loss of calcium. It's well known that this is a physiological process of aging where osteoclasis outdoes osteogenesis and we lose bone. Women have it worse than men due to the menopause and the loss of estrogen, which accentuates this process. This leads to a mechanical integrity of the bone, which is lessened through thinner cortices and wider intermedullary canals, which we will discuss later on in the talk. Patient also, and this does not necessarily mean they have to be elderly, but they can be poorly conditioned, they can lose muscle or be sarcopenic, they can have difficulties with balance, poor vision, some medication, resulting in a propensity to fall. You fall with weak bone, you may end up with a fracture, or if you have very weak bone with normal activity, you may end up fracturing. This leads us to the definitions of what we will be talking about. Fragility fracture is that caused by an injury that would be insufficient to fracture a normal bone. It's the result of the reduced compressive strength or torsional strength of the bone, and this is the World Health definition of a fragility fracture. An insufficiency fracture is a fracture that basically is caused by normal physiological activity on very weak bone. It's a progressive event and may be considered a stress fracture in very osteoporotic bone. One must also understand the concept of pelvic instability. The pelvis is essentially a ring structure, as you can see in the upper right picture. It has ligaments at the back and at the front, which hold the bones together through the sacroiliac joint and the symphysis. The problem with instability is that when the bone fractures, as you can be seen in the lower fracture with a lateral compression injury, the bone will fracture, and depending upon where it goes and what ligaments or bony structures are broken and in complete, will be the potential for this bone or the pelvis to move. This motion causes pain and essentially limits patient's mobility until stabilized. And this is the difficulty that we face in this type of fracture pattern. Well, what's the epidemiology? Is it a common injury? Is it not? Well, the general statement states that 92 out of 100,000 patient years, you will find the incidence of this fracture. 75% of these are women. In a city like Houston, where I live, the population of about 5 to 6 million, this means there will be about 5,000 of these fractures a year. They are associated with poor bone, essentially osteoporosis, and usually with a fall. 73% of these fractures are in the elderly, but there are a small number that will occur in patients who are taking some drugs or medication that will weaken their bone. And this is increasing rapidly. It's going to be increased. That number up there of 92 will be 2.4 times that of what it is now in 2030. These graphs are from Finland, which has a very good registry for fractures. And you can see, as you transglate across the graphs, that over the years, from the early 90s right up to 2030, the gradual increase, or fairly rapid increase, of elderly pelvic fractures that will be occurring. The other aspect of this is, what is the outcome on these fractures? First, we can look at it from a survival point of view, or mortality. This is work that's been done in Germany and Holland, showing that pelvic fractures have an incidence of a mortality. Obviously, the older you get, the closer and faster you will gradually die, as you can see in this graph. But this does not really deal with pelvic ring injuries at all. This is just the general population. If we look on this slide in the red box, you can notice the 1-year mortality as compared to the mortality at 1 year of a population with no fracture. One column on the left shows definitely that if you have a pelvic ring injury and you're elderly, you have a much higher incidence of dying than if you did not have that fracture. What about both mortality and morbidity with regards to this? This is another study out of Germany looking at a large registry of over 5,600 fractures. 21% of these fractures died if they had a fracture, or only 11% died without a fracture. And in fact, if these patients were admitted to hospital with only immobilization, in any given series, there was up to a 54% chance of complications. Well, this is like a hip fracture. Can we change this and improve the care on this? Well, if we look at the outcomes of this, you can see here non-operative care in the things at 6 weeks. The SMFA and EQ510, which are patient-reported outcomes, are decreased by 25% over the normal for the same age group. This also occurs with more unstable fractures as well. So just looking at this, we have an increased mortality, we have a decrease in function, and this is also confirmed in this study as well, looking at the Dutch population of older individuals with an average age of 79. And again, you can see here that with the SMFA, which is a functional outcome, or the EQ50 again, that definitely that the patient with the pelvic fracture, which are the bolded numbers, are less than an average patient at the same age without a fracture. So again, functional outcome is significantly changed and decreased with a pelvic ring injury. This is a series of other papers, all of which confirm the same aspect and the same problem with fragility or insufficiency fractures of the pelvis. So can we do better? Well, here is the evidence going along in the literature. Both of these graphs show an increase over a period of time, one from the early 1990s and one from 1976, of the number of papers that are now being published looking at this problem. So obviously it has now been recognized, and we'll now look at and see what these papers are beginning to tell us with regards to this. First is the pathophysiology of why does this occur. You can see in the bottom pictures that where the arrows are, there are several large holes in the bone. This is where you lose bone when you become osteopenic or osteoporotic. This is through the ala of the sacrum, and this is where the weight-bearing forces are transmitted from your legs to the spine. So you can obviously see what will happen as you lose bone there. There's an increased incidence of fracturing from that area. If we look at the progress, if we don't treat some of these, they will gradually go on and deform. And this is just the example of that, showing the initial x-rays on the left and then the CT scan on the right. And you can appreciate the deformation on the right-hand side of that lower corner picture as the fracture has healed. Insufficiency fractures are similar, although this, as I mentioned, only occurs with normal activity. The first part you get is usually an MRI change in which the bone gradually will fracture and break, but nothing will be seen on x-rays. As time goes by, this gradually progresses, and again, because of how the spine is loaded at the sacrum, this will gradually go through and on the right-hand side create bilateral sacral fractures and fractures across the sacrum, which are particularly hard to heal and can be particularly painful and unstable. And this is just an example of an insufficiency fracture, again, showing a deformity. And in fact, this fracture has not united. As you can see, the wide gap at the front of this injury, and this patient has ongoing pain and discomfort. Well, what about the diagnosis? With the acute fragility fracture, sometimes it's difficult to determine because a lot of patients are poor historians. The fall or the injury may not be significant. So some people are ignored or forgotten about and not really investigated. Sometimes these patients are on anticoagulation, and even though these are low energy injuries, their vessels can be calcified and potentially able to break and bleed. So this is not something that you need to put down and not use here. It is something to keep in the back of your mind. And also consider the risk factors involved in this: vitamin D deficiency, which many of us are, hypocalcemia, diabetes, and even nicotine abuse and occasional overuse of alcohol. With a chronic sacral insufficiency fracture, again, remember, there's no history of trauma. It is usually the development of back and buttock pain. In this circumstance, we have the same risk factors, but more importantly, there can be delays, and some of these delays are usually averaged about 55 to 60 days from the onset of pain, or occasionally up to a year or 2 years, while people are looking for or trying to diagnose why do they have ongoing chronic low back pain. And sometimes it's difficult to see these on x-ray. Physical examination, well, one may ask why. We have many radiological investigations, but it's also important to understand that in these patients, since x-rays may not be telling of a fracture at times, that to examine the patient, you can push on the pelvis in various ways and see if there's pain or motion. But these two tests, the Gauselin and Fabry test, interestingly enough, in this one paper by Newcomb, showed that they were 83% successful in predicting and detecting a posterior injury through the sacrum by physical examination. This is very helpful when assessing a patient, particularly an insufficiency patient, to clue in where one wants to investigate and look critically at your investigations. Diagnosis can be done by radiology. Plain x-rays are always done, but it is very difficult to see these fractures. As you can see on the CT scans, they're very minor in the sacrum. It has been shown that you can basically identify up to only 20 to 38% of some of these fractures due to their minimal displacement and poor bone quality. This has been confirmed in the literature by Gertzbein back in 1977 and Newcomb recently, again demonstrating that there can be no such thing really as an isolated pelvic ring injury. You need to make sure that you rule out the injury posteriorly. This is usually done through a CT scan. So in anybody who has a positive physical examination and x-rays of pubic rami fractures at the front, nothing had seen in the back, a CT scan is definitely mandatory. Even they will miss some, and it's been said that the CT scan is only 75% successful in identifying these. You also need multiplanar reconstructions, essentially to see a transverse sacral fracture, as demonstrated here on the right hand, a CT picture. And this is just an example of an X-ray. You can look at it and you see that there is a parasymphyseal fracture, but when you look critically on the X-ray, very little is seen, but the white arrows are demonstrating where the fracture is on these reconstructions of the CT scan. Next step, if there's nothing seen on a CT scan, is the MRI. The MRI is 92% sensitive and 98% specific for fractures. It is particularly using the T2 and STIR images where this is very helpful. And one can see that on the right-hand side, the little area in the sacrum that is now seen, whereas you do not see this on the CT scans on the left. So MRI is important. This brings up, if you look here, a diagnosis radiographic algorithm. Basically, if you have a patient who has fallen, who has back pain, limited mobility, and you have an X-ray, you can either have two situations. You may have a fracture, which if so, you will go and probably get a CT scan and then diagnose the fracture and move to appropriate treatment. Should there be no fracture, then one would mobilize the patient and see how they do. Should they not get better, again, CT scan. If the CT scan is negative, MRI, and then appropriate diagnosis and management to follow. So this brings to the next part of the area, is how do we classify these or describe these fractures to help us in our treatment? They're, as they say, the majority are elderly and lateral compression injuries. And there are other pelvic ring fracture classifications, but these are basically used for high energy fractures. Romans has come up with one that takes these fractures and tries to define this concept of instability and tries to determine treatment. In this classification, he says that the first criteria is the degree of instability, or clinically, pain and loss of ambulation. This is based on the fact that either the fracture is non-displaced or displaced, and where does it occur within that pelvic ring. This leads to 4 different types, and further definition of these fractures shows that a non-displaced fracture, which are crush or some fracture without deformation, he called stable, and displaced fractures in which their anatomical deformation is shown through the fracture were considered unstable, and then place these into the posterior pelvic ring in various locations. We'll now just briefly go through this to show you what it's meant. A type 1 is an anterior injury only. Basically, you have ruled out through MRI and CT scan that there is no evidence of a fracture in the sacrum or the posterior pelvic ring. Uncommon, about 17% of patients have this fracture. The type 2, this is the problem. These are non-displaced posterior injuries which are potentially unstable. The first type is a type 2A, which is non-displaced posterior lesions, then 2Bs, which are anterior crush, and 2Cs, which are non-displaced fractures. We'll just look at these and how they stand and come through, and we can see their incidence. The 2A fracture with no anterior ring is a very rare injury. This is probably a sacral fracture and probably is stable and will not really have any other problems associated with care other than immobilizing the patient. The 2B fracture is the anterior crush injury with a fracture in the pubic rami, and you can see that little crush through the sacrum at the arrow on the right hand picture through the CT cut. This is a common injury, and the problem here is, are these really stable or unstable injuries? And that is something we will deal with later. The 2C injury now is a complete fracture through these areas, but it's undisplaced. Remember, in this classification, Rowan said that this was a supposedly stable fracture, but has potential instability. The other fractures, the type 3 fractures, are unstable fractures as these are displaced. The 3A is fractures through the ilium and it's displaced. 3Bs are through the sacroiliac joint, and 3Cs are through the sacrum. These are usually typical of a higher energy fracture, more commonly seen with motor vehicle accidents and falls from a much higher height than standing that cause the fragility fracture. Final is the 4 group, and these are bilateral posterior injuries. And they come in various and sundry fashions. You can have the ilium, the sacroiliac joint fractured. You can have a fracture that runs through the sacrum in a transverse fashion, being what's known as a spinal pelvic dissociation, which is a very difficult injury to treat and very uncomfortable with potential neurological problems for the patient. And then finally, the 4C, which is a combination of many different kinds of injuries, which is extremely uncommon in this age group. This classification is well defined. It has, as I said, 4 types. Its inter-observer and intra-observer variation is as good as the Young, Burgess, and Tile AO classifications that are used in high energies. It covers 90% at least of most of the fractures and has some relationship to the mechanics, but doesn't really deal with the clinical aspects and patient characteristics that may control whether they get surgery or not with regards to this. So, classification of insufficiency fractures, which are slightly different, is essentially one of worn out bone. In this circumstance, these fractures they begin usually through a bone bruise as seen only on an MRI. This will gradually progress into a situation in which the fracture then moves into the ala of the sacrum, and then from there will start to deform the bone itself. This can then move on and become fractures through the sacrum and right on through that into the so-called spinal pelvic dissociations, much the same as we saw on the insufficiency fractures. So it is much the same, but really is only caused by activity and not a fall or trauma. All of these fractures have a potential to progress, and this just demonstrates the progression in this. You can have up to 29% of these patients getting a deformity as they heal, which may be one of the reasons for the decrease in function in these patients that have been treated before non-operatively. Having made the diagnosis and having now gone ahead and determined our fracture and classified it and understood that we have one, what is the management now as we go towards this? Well, our management goals are 1, pain relief. That is very important. We want these patients to be up, mobile, full weight bearing, because we know that decreases their incidence of complications in the hip fracture patient, and they do better at home and out in the community. They want to be as high a degree of independence as possible, and we want to use safe methods that do not have complications and will provide proper pain management for these patients. If you look at this slide, this is the old-fashioned way of treating fractures. It's what I was trained to do many years ago. They were placed on bed rest. When the pain resolved, they would be mobilized. This could be anywhere between 5 to 10, 12 days, 2 weeks. The results of this, when people began to look at it, showed that there were long lengths of hospital stay and high mortality in this. If you look at this, you can see that adverse events occurring in the hospital are high in the red bar. In that purple bar shows the independence of the patient prior to being admitted to hospital and being treated. The blue bar shows the decrease. And then the mortality is in the gray. And as you can see, everything gets worse with this type of treatment. And hence, people have called this into question as being the correct way of doing things. So, how do we do this? How fast do we mobilize patients? What is the limit of pain? How quickly, if they are going to go to the operating room, do we need to do this? We obviously have to look after their bone health to prevent further fractures. And the big question here is how do we determine this? And this is based on trying to determine the fracture stability or instability, which in the pelvic ring is a spectrum, as you saw through the classification. It is not like a long bone fracture, such as a femur, where the bone's broken, and it is broken and it's unstable. There are patients who do well and do have minor fractures and are going along fairly well with this as well. We have two choices. The first choice is early mobilization in all patients and just see what happens. Sort of like putting your head in the sand, saying, oh, okay, everybody's going to do well, let's just get on and see. Or we can assess the pain and instability. And if these patients cannot move and are unstable and painful, then we could consider some form of operative treatment for these. The question is how fast and how quickly do we need to do this? Non-operative management nowadays is usually adequate pain management with some form of analgesic medication, mobilization of the extremity in bed and quickly getting up within 24 hours, sitting and standing at the bedside, transfers, and then walking with a walker up to about 50 feet. And this should all be accomplished within 2 to 4 days, and then the patient can be discharged and carried on. What are the results of this treatment? Well, this is one paper that was looking at the older age group, greater than 60. They had a length of stay of 4.6 days, and only a third of these patients got admitted to hospital. There was a greater than 1 centimeter displacement in 28% at 6 weeks, but 45% of the overall group had a displacement of greater than a centimeter at the beginning as well. They stated there was no need for any advanced imaging. You did an X-ray, that's all you needed. All patients were ambulatory at 6 weeks, and none required surgery. However, in this study, there's no patient-reported outcomes. There's no mortality figures. It is just purely saying that they all got up and did well and went away. So this is questionable as to what its outcome and what its validity is. Another paper looking at a much greater spectrum of patients, younger as well, with high energy injuries. They did show here that if the fracture was stable and the patient could mobilize and get up and get going, then these patients did well and had no problems. They did recognize and eliminated out of their study those patients who had fractures that would not allow them mobility and activity within the first couple of days. So this does show you that if you have a very stable fracture, that you can get up and get going, that you will probably be okay. Well, how do we evaluate this degree of instability? We know from the classification that those type 3 and type 4 fractures are going to require some form, at least, of operative intervention and be offered to the patient. Whether it's done or not, based on other patient characteristics, is a clinical decision. However, in that type 2 group, the group that's potentially unstable or that are really minimally displaced, how do we determine what is unstable? Is it through mobilization, pain, clinical examination, x-rays, or examination under anesthesia? This is something we'll just look at the present time. So, fracture stability assessment. How do we go about this? Well, first, how fast should it be done? We should treat these patients like they were broken hips. Assessment of their medical problems within the first 24 hours, the use of cardiac investigations, echocardiograms, etc., if they meet the American College of Cardiology standards, and other investigations as fast as possible, so that if they do need surgery, it can be carried out fairly quickly. We want to assess these fractures, as we've told, with appropriate x-rays and CT scan and MRI. And then with the type 2, we want to really start to try to mobilize these patients and see how they do, and then look at their outcome. So a trial of mobilization is usually done over a period of 2 to 5 days, and the patient should be able to get out of bed and get into a chair and walk at least 50 feet. After this, you get some x-rays to assure the fracture has not changed, and then these patients can be discharged and followed very closely in case there is some displacement usually at 2, 6, and 12 weeks. And by 12 weeks, they're usually healed, and they're appropriate now for a bone health assessment to be placed on osteoporotic drugs at that point. And the next thing is, well, what happens if they don't mobilize within that 3 to 5 days? Then what do we do? And this is the group of fractures that we need to look at with regards to instability. So one can push on the pelvis, like we showed in the physical examination, but this doesn't really say much to you. This basically tells you, yes, they have some pain. We've already done this. But what do we do next to confirm our clinical examination that there may be a problem? We can look at x-rays alone, but as I told you, plain x-rays don't really show you a lot of these fractures. We can add CT scans to it, but again, it may not be complete. But if you have a complete fracture through the sacrum, where the dorsal cortex on the back is involved, then you have the potential for having an unstable fracture, particularly if you have a multifragmented ramus fracture near the symphysis or bilateral pubic rami fractures as well. Fractures through zones 2 and 3 of the sacrum are more unstable, as we mentioned, because these move into the spinal pelvic dissociation group. What about the pubic ramus injury? We mentioned that. Well, it's been shown that if you have fractures in the parasymphyseal region, or that region right by the symphysis, known as an Cantani number 1 fracture, or you have a lot of anterior displacement, or there are 2 fractures in the superior and inferior pubic rami, this is usually related to a more unstable. University of Texas, Houston, we looked at this as well and confirmed that these fractures in 150 patients did predict instability at the back of the pelvis. Beckman has done it in a different way. He has taken the CT scan and created a scoring system based upon where the fracture occurs, how it occurs, what it looks like, and has come up with basically a scoring system saying that if you have less than 6 points, you are stable. If you have greater than 10, you're unstable. And this was based on some of their determination of patient mobility and treatment. So you can use a CT scan. One can use physical examination in using an X-ray as well. This is a paper by De Kaiser from Utah showing that an examination, supine examination, stressing the patient in the emergency department awake by just pushing and pulling on the pelvis can demonstrate instability. In their study, they showed that out of 70 patients, 13 of these had a positive EUA, and when taken to the OR, correlated with an unstable fracture. The other 57 patients, 55 healed without any problems, but 2 of those failed, and they were 2 complete sacral fractures that they had missed. They had recommended this for high energy injuries, but it may also be particularly useful in assessing this in the type 2 Romans classification of pelvic ring injuries. They also did an interesting study, which they reported, where they looked at 70 patients and applied the Beckman scoring system and then did an EUA. And it's interesting what they found out, that if you get a score of 7 or greater than 12, then you do not need a stress x-ray because your pelvis is either stable, you're going to get up and be able to move, or totally unstable. The group that scored 8 to 11 needed a stress x-ray. So this helps us a lot in trying to determine how we might categorize our patients and their treatment with this injury. You can do a stress x-ray by turning the patient on their side. This is comfortably and can be done. And again, it will demonstrate instability. This was done by Perry, and his results demonstrated here show that when you look at the left-hand columns, you can see those patients with greater than 10 millimeters of displacement. You can see that they all had more operations. They had a longer time to being mobilized and walking, and they also had increased use of morphine equivalents in their time prior to their surgical intervention than compared to those with less than 10 millimeters of displacement, which were considered stable and did not require any operative treatment. The other aspect is a examination under anesthesia. You simply consider the patients who cannot mobilize within the first 2 days or so. If they have pain and they can't be up and mobile, you bring them to the operating room, you put them to sleep, and then you move on and push on them. This has been popularized by Chip Rout, who is in Houston, as a way of doing this, because if they are positive, then they will end up with a surgical treatment. If not, then they can be mobilized safely. So this is one technique that it can be done as well. And if we look at the patient that we began with, our 75-year-old lady, you can see on the left-hand side, prior to being examined, her pelvic inlet here looks very good. And you want to do this using the pelvic inlet view. When you see the stress applied on the right-hand side, you can appreciate at the arrow the displacement of that pubic ramus, which also is displaced through the posterior aspect. And this so-called relatively stable looking pelvis is unstable, and she will probably need some form of operative intervention. Saji has also changed this to a bit. He does these with the patient's legs tied together and two people pushing and pulling. Interestingly enough, he has classified these unstable fractures as what's known as a lateral compression 1B. This is the addition to the Young Burgess classification, where lateral compression injuries as the first type are considered stable. And the x-rays are the ones that we're talking about in the Romans 2 injury pattern. So this is just an additional way of helping us classify our fractures. The other aspect has been brought up by Jane is perhaps we also need to think about pushing on the leg and seeing if there's any vertical stress as well in this to may also change how we look at things. So this then brings up your algorithm having made your discovery. You can state basically that the 3 and 4s are definitely going to be offered surgery. Your type 2s will be probably mobilized. If they mobilize well, we'll go on to a non-operative care. If not, we'll go down this route, down the right-hand side here, across into the red, be reevaluated, and then undergo some form of operative treatment. So we're beginning to try to define this instability and making a logical treatment decision based on these fractures. Well, having done that, what are our techniques? And as I mentioned, nowadays these are all done percutaneously, and so it is a much safer operation than it was with a large open reduction. This brings up the principles of this, is that we want to be less invasive and percutaneous. We want to construct stability, or our internal fixation is probably going to be more important than getting a perfect anatomical result, but we must reconstitute anatomy to be able to get our fixation in. And we want to enable early mobilization with full weight bearing, or weight bearing is tolerated as soon as we can post-operatively. Remember, I talked about osteoporosis, and the problem here is what happens with the bone. The cortices, which is the strength portion of the bone, gets thin. So any type of screw fixation is not very good in cortical bone. The other side of this is that any place where there's an intermedullary canal, classically the femur, but in the pelvis, there are a series of corridors which act like intermedullary canals. They lose bone, they become larger, and we need to think about how we're going to stuff these with some form of internal fixation. Finally, any screw purchase into cancellous bone, because the cancellous bone is also becoming less obvious and weaker, these screws, etc., will not hold. So again, what we'd like to do is we'd like to get purchase of some kind of screw fixation, and as much as we can in the corridors to provide stability for the fracture. This has brought up the whole concept of bridging or splitting these fractures using some kind of intermedullary screw fixation, or stuffing the S1, that's the sacral, upper sacral segment, and then the next segment of the sacrum with internal fixation, as well as potentially the rami, and making sure that the screws and size of your implants will fill these canals. The longer you can do this, it's better. So if you can go transsacral, it is better than iliosacral. And sometimes one may consider augmentation, which is the addition of either methyl methacrylate bone cement or a bone substitute, as we will see. You can use washers or 2-hole, 3-hole plates to buttress that thin cortex so the screw doesn't intrude. And you should usually try to get a second area of supplementation, as we will see. And there's also been some evidence that you can inject cement, that's the bone polymethyl methacrylate, into the sacral fracture, but it does heat up and it does leak, and there are neurological structures nearby that could be potentially damaged. One must remember, though, that in many of these patients, there's a thing called sacral dysmorphism. This is a change in the normal sacrum so that it is difficult to get screws in place. And one can take a look at this and see that this occurs fairly commonly. And this is just a study looking at a series of 3D models. And if you are trying to place a screw through that upper sacral level, the S1 level, you're going to have 52% of the time, it is going to be a problem. Second of all, in the S2 level, it could be a problem. And if you look at it, 26% of the time, this was done at S1 and could not be done at S1, and 0 times in S2. So S2 is consistently there for a screw. However, it just means that the orientation in the upper sacral segment must be changed, as one can see in these pictures. The middle picture shows this oblique fashion of placing 2 screws into the sacrum there, and it is obvious that you cannot place a screw all the way across as you see at S2 in the lower picture. So one has to be aware of this dysmorphic pelvis in order to get your screw fixation in these groups. So what can we do? Well, we can place multiple screws in the upper sacral segment. That will work, and it will work in patients who may not be stressing the pelvis extremely a lot, or trying to get a lot of function out of their pelvis. This may also be done with a very large transsacral bar, which will fill that S1 corridor like this on the x-rays, where you can see the bar going across. It has been supplemented by another screw into the sacrum as well. But this will effectively stuff that S1 corridor. The other aspect of it, which is probably a better and safer way, are 2 sacral segment fixation, one in S1, one in S2. And in this patient, one can see the fracture here, down and at the back. You can see the CT scan demonstrating that very benign looking sacral fracture, but the patient could not mobilize and was taken to the operating room where she underwent an EUA. Again, you can see here at the black arrows the significant motion that occurred. She then went ahead and had 2 screws placed, one in S1, upper sacral segment, one here, and one through her pubic ramus, which we'll discuss in a moment. Pain was improved, she was mobilized and out of hospital in several days and healed by 3 months. There's a technique using a new device called a curved intermedullary fixation. And in this circumstance, again, you can see the pelvic ring injury through the sacrum. And the problem now is with these screws, it is difficult to get a transsacral screw. With this curved intermedullary fixation device, which is mobile, it can be placed around and curves around and then can be strengthened and tightened due to its construction and provide, again, a significantly important structural stuff type of fixation through the upper sacral segment, and the patient will heal and has done well. This is the use of augmentation, and as you can see here, what is being done is the guide wire has been placed, a drill bit across there, and then the screw is placed in, and methyl methacrylate or bone cement calcium phosphate is injected through the cannulation of the screw into the sacrum to provide augmentated fixation of the screw threads. This just demonstrates where it is here, and you can see the screw on the lower x-rays and the whiteness around it, which represents the augmentation. If we look at this, is this work or not? The mechanical studies basically do not show what exactly is happening at this time, that it really works any different than regular screw fixation. The meta-analysis of the results, again, not much different, but we can say it's clinically safe. Finally, the management of 4, 3s, and 4s. We know what they are. They are operative, and they will be done in a standard fashion, such as here, using percutaneous fixation through the sacrum and the bodies as well. This is another example of a type 4 with the H and the paradoxical inlet. And again, you can see the x-rays, the transverse sacral fracture, and subsequently stabilized with 2 screws due to the fact this patient was not mobilizing well due to other injuries. And this patient had a more significant fracture and stabilized with what's called lumbopelvic fixation, which is the conventional way of handling this. Anterior ring needs to be stabilized as well in these patients, and this can be done using screw fixation as seen here, generally, or with plate fixation. But be aware that it is not all as easy as it seems, as sometimes the pubic ramus will not take a screw and will need it to be plated. However, in this study, you can see that screw loosening with the plates is potentially a problem due to the poor osteoporotic bone that's used. This is just an example of that technique. Finally, looking at our post-operative management, we get weight bearing is tolerated, follow-up x-rays at 6 and 12 weeks, and both health evaluation and treatment, usually at 6 weeks. So what about our outcomes? How does this work? Well, now we're looking at it. In this 7-year follow-up on 128 patients, of which about 18% or 40% of these had operative position fixation, 3% had screw pain and malposition, which were revised. But there was no significant real differences other than the patients lived longer or their mortality was better. In this group, this looked at several different aspects. One can see that pain on admission was on a VAS scale of 0 to 10 was 6.8. After 6 days was still 6, but post-operatively dropped to 3.6. And at discharge, these patients had 1.8 on their VAS scale, which showed that the fixation certainly controlled their pain as well and improved their mobility. And at the long-term follow-up in 31 months, the majority of these patients had no problem and were mobilizing very well with no reoperations. Again, another study looking at this showed that in the group patients who were operated on in the green, mortality is 10% at 1 year, 73% at home, and if you look on the red, those who had non-operative from the same clinic, 50% living at home, 18% at 1 year were having problems and had died. Transsacral bars, similar results. Patients at home and walking and having a much better mortality than those who were non-operatively treated. These graphs, again, show the same thing. The darker line represents those without fixation, and the other line shows those with fixation, again, showing the improved mortality that occurs with internal fixation. However, this paper did demonstrate with operative intervention that there is a complication rate as it would be expected over the non-operative group. But again, the change in mortality was significant that operative care probably gets around the complications in this group. Using a standard protocol, as we talked about, showed that these patients could regain injury fairly quickly and do very well and did not get any malunions as well. Again, another one looking at a standard operative procedure like we have talked about, again showed that they did well. Their survival was much better than the non-operative group, and the mortality was better as the ambulatory patients at 1 year did not seem to change very much. Sacral insufficiency fractures with internal fixation do well, as you can see here. Their Oswald Street low back index dropped down to 14.6, which is significant improvement in these patients. We may also treat these with teriparatide, which is a drug that increases bone healing used in osteoporosis. And we've talked about this sacroplasty as another way of looking at it. These just demonstrate sacral insufficiency fractures and the various tags of trying to treat them. So where are we now? In a systemic review of 766 patients, the conclusions was that operative intervention improved pain, there were minimal complications, failure with non-augmented single joint screws was higher, and they could not draw any real conclusion whether it was any better operatively or non-operatively with regards to function. Another paper, again, this one showed that looking at the 2B fractures, again, there was some evidence that non-operative care and operative care were similar, but again, mortality at 1 year was significantly improved in that group. The other dilemma is, since we as orthopedic trauma surgeons are the only ones who do percutaneous fixation, in a city like Houston with 5,142 fractures and only 3 potential sites to deliver care, this might mean that there's 214 patients per year per site. This is a significant number of patients on top of everything else that's done in trauma units. So one must consider how we are going to do this and how we will go through the evaluation and treatment of these with regards to surgeons. So as we come to conclusion, if we look at a treatment algorithm, we have the low energy injury with pelvic region pain. We've gone through the assessment, clinical compression tests, or other tests that demonstrate that there is an injury. If there is no injury, we'll rule out anything else that's going on, such as occult hip fractures. If there is an injury, we see on the scan, on the pelvic x-ray, or we think there is, pelvic x-ray, CT, and if needed, an MRI. And in that circumstance, as we go ahead, we will then classify the fracture. And based on our classification, the 3s and 4s offered operative treatment without any worry about mobilization because they need it. And with the 2s, we will probably undergo some form of stability assessment, and this would be dependent on how one feels about this, either with X-ray, CT, or EUA, within several days if the patient doesn't mobilize well, and then proceed on to internal fixation at that time. As well, they must all have proper follow-up, proper bone health assessment, proper medical support. And in summary, I hope I've shown you that the fragility fracture pelvis appears to be emerging with increasing frequency. We have provided a classification and a framework for assessment and instability. We do need a treatment effective plan to achieve early mobilization as soon as possible. Operative intervention appears to be effective if non-operative care initially fails within the first couple of days, and we now have good techniques in which we will splint the pelvis and stuff the corridors to provide good care. So I appreciate the time you've taken to listen to this, and hopefully this will help you in the management of the elderly pelvis. Thank you.